In this video, I'm going to talk about central nervous system tumors. This is a list of pretty much all of the CNS tumors. I'm only going to cover the ones on the left side of this slide, the diffuse gliomas, other astrocytic tumors, ependymal tumors, choroid plexus tumors, neuronal and mixed neuronal glial tumors, embryonal tumors, lymphoma, and hemangioblastoma. When we're imaging tumors, the most important thing will be the conventional images, the pre and post contrast images. But we also want to look at diffusion weighted images because the more cellular tumors tend to restrict water diffusion, so they will be darker on the ADC map. We also will look at perfusion weighted images. Higher cerebral blood volume tends to be associated with higher grade tumors. Perfusion weighted images also are helpful in post-treatment imaging, which I'm not going to talk about in this lecture, but they are helpful in terms of distinguishing tumor progression from radiation necrosis. And finally, we will sometimes use MR spectroscopy, and I'll talk a little bit about that a little bit later on. So first, with the diffuse gliomas, more and more of these tumors are being defined by their genetics. So the diffuse gliomas include diffuse astrocytoma and anaplastic astrocytoma. These are mostly IDH mutant tumors. Similarly, the oligodendrogliomas and anaplastic oligodendrogliomas are also IDH mutant, and these are also 1p19q co-deleted. Glioblastoma is predominantly IDH wild type, 90% of them. And diffuse midline glioma, also known as diffuse intrinsic pontine glioma, also has a specific genetic marker. Okay, so let's start with the first case. T2 post-contrast T1 and perfusion images. We see a circumscribed mass, no enhancement, no blood volume elevation. This is typical appearance for diffuse astrocytoma. So a diffuse astrocytoma, typically circumscribed margins, does not enhance with contrast, does not have any elevated blood volume. This is generally an IDH mutant lesion, and it's a WHO grade 2. A few years ago, Dr. Patel and his colleagues described the T2 flare mismatch sign, and what that means is that most of the tumor loses signal in the flare compared with the T2. So if you look at the three examples on the right, you can see the tumor, all of the tumor is bright on T2, whereas when you look at the flare, the majority of it gets darker on the flare compared with the T2. And surprisingly, this had an extremely high specificity for IDH mutant 1p19q non-codeleted. So in other words, astrocytoma, but not oligodendroglioma. And the specificity was around 95%. So if you see this sign, T2 flare mismatch sign, you're almost certainly going to be dealing with a IDH mutant astrocytoma. Unfortunately, the sensitivity is not so high. It's only about 1/4 to 1/2 of the IDH mutant astrocytomas will have this T2 flare mismatch sign. There's also an anaplastic variety of astrocytoma. It's a little more heterogeneous than the standard astrocytoma, but it's not necrotic like a GBM. It may have some contrast enhancement. The cerebral blood volume may be a little bit elevated. Again, this is IDH mutant, and this is WHO grade 3. And if you look at this example here, this probably has I don't have the T2 weighted images, but it probably has the T2 flare mismatch sign. If you look, most of the tumor is not that bright on the flare. Probably this was all brighter on the T2, so this one probably did have the T2 flare mismatch sign. Another patient here, we have a T1 pre-contrast, T1 post-contrast, and cerebral blood volume images. So here the lesion has indistinct margins, does not enhance with contrast. It's in the frontal lobe, centered in the cortex, and maybe it has a little bit of blood volume elevation here. And this is an oligodendroglioma. So oligodendroglioma, indistinct margins, heterogeneous appearance. They're most often in the frontal lobes, often centered in the cortex. They frequently have calcifications, so this is a very helpful sign. If you see calcifications, we're often dealing with an oligodendroglioma. Little or no enhancement. With oligodendroglioma, even the grade 2 tumors may have a little bit of elevation of the cerebral blood volume, and these are IDH mutant, and they have the 1p19q code deleted and WHO grade 2. And then the anaplastic oligodendroglioma, similar to the oligodendroglioma, tends to have a little bit more contrast enhancement. Again, tends to have an elevated cerebral blood volume, and this is a WHO grade 3. Flare, post-contrast T1, perfusion, heterogeneously enhancing mass, a lot of necrosis, elevated blood volume, glioblastoma. These are heterogeneously enhancing masses with irregular margins. They often have necrosis and hemorrhage, a lot of peritumoral edema, elevated blood volume. Most of these, 90%, are IDH wild type. They're WHO grade 4. So with the glioblastomas, about 90% are IDH wild type, 10% are mutant, but there's quite a big difference between the two in terms of age at diagnosis. The IDH mutant present at a younger age. They have a longer duration of symptoms before they present, and the survival is substantially better. The median survival is about double for the mutant type than for the IDH wild type. I'm going to take a couple of minutes here and talk a little bit about MR spectroscopy. So here's a patient. We can see a lesion in the left frontal lobe, bright on T2, bright on the flare, and has just a little bit of enhancement with contrast. So let's just take a look at the MR spectroscopy. And this is a standard MR spectroscopy. And the usual MR spectroscopy, we're mainly looking at three metabolites, choline, creatine, and NAA. So the slide on the left shows the normal right side of the brain with normal appearance of choline, creatine, and NAA. The slide on the right shows the typical appearance for tumor. This one has a very high choline, much higher than the creatine, and a low NAA. And so this appearance with a very high choline, a low NAA, tends to correlate with a higher grade tumor. And in fact, this turned out to be a glioblastoma. But in general, the spectroscopy is not that helpful. So I would say generally it does not add much to the standard imaging features. I want to just talk a little bit about isocitrate dehydrogenase. So we've talked about IDH mutations. Just to go over what exactly this means. So isocitrate dehydrogenase converts isocitrate to alpha ketoglutarate, and there are two varieties, IDH1 and IDH2. IDH1 is in the cytosol, IDH2 is in the mitochondria. Now, the IDH mutation has an additional function that's not found in the regular IDH enzyme. So the IDH mutation will also convert alpha-ketoglutarate to 2-hydroxyglutarate. So normally there's no 2-hydroxyglutarate in the cell unless there's an IDH mutation. So a couple of years ago, a group was able to detect the 2-hydroxyglutarate using MR spectroscopy in patients with IDH mutated gliomas. So this could be a very important thing because, as I said, there's no 2-hydroxyglutarate in normal cells. So if you can detect 2-hydroxyglutarate, it means that there's an IDH mutation. And these are, now you can't do it with, it's the spectroscopy technique that they used is much more sophisticated and is not commercially available yet. You can see the spectra on the top is from a IDH mutated tumor, and you can see it. This is the choline here, creatine, NAA, and the 2-hydroxyglutarate is somewhere in this squiggly stuff here. You can't detect it on the standard spectroscopy, but with specialized techniques, you can kind of tease out that 2-hydroxyglutarate peak. And so in this one, the peak was present, and this is an IDH mutated glioma. And the one on the bottom is a patient with a GBM. Here's the choline, creatine, low NAA. This one has a elevated lipid lactate peak, which we often see with the GBM. But this one has no 2-hydroxyglutarate peak. So this was both very sensitive and very specific for IDH mutation. Unfortunately, it's not yet commercially available. Hopefully, this will be available sometime and will add a lot of benefit in terms of our imaging gliomas. Here we have a mass diffusely infiltrates and expands the pons. It engulfs the basilar artery. You can see it surrounding the basilar artery over here. Little or no enhancement. Diffuse intrinsic pontine glioma. So this is most often seen in children. It expands the pons and it often engulfs the basilar artery. Little or no enhancement, and they usually do not have hydrocephalus. Most of the tumors that have this imaging appearance that we consider a diffuse intrinsic pontine glioma are H3K27M mutant diffuse midline gliomas. The prognosis of these is very poor, even though the histologic features sometimes may suggest a low-grade tumor, and they don't enhance. These are WHO grade 4 with a poor prognosis. On to other astrocytic tumors. The pilocytic astrocytoma and subependymal giant cell astrocytoma are WHO grade 1. Pleomorphic xanthroastrocytoma and anaplastic pleomorphic xanthroastrocytoma, WHO grades 2 and 3. T2, T1, post-contrast T1, cystic lesion. If we look carefully, it has a little bit of an enhancing component. Here's sagittal T1 pre and post. This nodule here enhances with contrast. So we have a cystic mass with an enhancing nodule, pilocytic astrocytoma. You can see growths of the large cyst with a nodule in the wall here. So these are Typically a cystic mass with enhancing nodule, most often in the cerebellum, also occur optic nerve and chiasm around the third ventricle and in the brainstem. Usually these are seen in children, but can also be seen in adults, and they're WHO grade 1. On the CT, we can see numerous subependymal calcifications, indicating the patient has tuberous sclerosis. We see a shunt catheter here. Here's T2, T1, and post-contrast T1. Enhancing mass into the foramen of Monro in a patient with tuberous sclerosis. This is a subependymal giant cell astrocytoma. So typically this is an enhancing mass near the foramen of Monro. All the patients have tuberous sclerosis, and these evolve from a subependymal hamartomatous nodules. They're WHO grade 1. CT and post-contrast T1. Fairly superficial enhancing mass with an adjacent cyst. This is a pleomorphic xanthroastrocytoma. So it's a superficial mass. Often the enhancing component often abuts the meninges, and then the cyst is deep to it. Usually adolescents or young adults presenting with seizures, and this is a WHO grade 2. Ependymal tumors, subependymoma and myxopapillary ependymoma are WHO grade 1, and then ependymoma and anaplastic ependymoma are WHO grade 2 and 3. T2, flare, post-contrast T1, circumscribed intraventricular mass, no enhancement. This is a subependymoma. These occur in two different locations, either in the fourth ventricle or in the lateral ventricle adjacent to the septum pellucidum. No enhancement, and that's an important distinguishing feature of this tumor. These are often incidental findings, and they're WHO grade 1. T1 and T2 weighted images, intraventricular mass that extends through the fourth ventricular foramina. This is a typical ependymoma. This is a gross image showing the ependymoma, how it conforms to the ventricle and extends through the ventricular foramina. So these often extend through the foramina of Luschka and Magendie, often have hemorrhage and calcification. Usually these are seen in children. Supratentorial ependymomas are often not in the ventricles, so they're ependymomas that arise from ependymal rests that are often adjacent to but not in the ventricles. Ependymoma is also the most common spinal cord tumor, and these are WHO grade 2 or WHO grade 3. Choroid plexus tumors, choroid plexus papilloma is grade 1, atypical choroid plexus papilloma, and choroid plexus carcinoma is a WHO grade 3. We have a pre-contrast T1, flare, T2, and post-contrast T1. We see an intraventricular mass, frond-like appearance, strongly enhances with contrast. This is a choroid plexus papilloma. On gross, you can see that frond-like appearance of the tumor. These often present with hydrocephalus. They're vascular tumors. You may see flavoids, blood products. In children, these occur in the lateral ventricles and in the third ventricle. However, when you see them in adults, They usually are either in the fourth ventricle or in the foramina of Luschka. And about 20% of these are carcinoma. Neuronal and mixed neuronal glial tumors, gangliocytoma and ganglioglioma are both grade 1. Anaplastic ganglioglioma, grade 3. Desmoplastic infantile astrocytoma and ganglioglioma. Dysplastic cerebellar gangliocytoma or Lermite Duclos. And dysembryoplastic neuroepithelial tumors, all grade 1. And central neurocytoma is WHO grade 2. T2, post-contrast T1. It's a mass with both cystic and solid components centered in the cortex. There's no surrounding edema. So our differential for this type of a lesion could be pleomorphic xanthar astrocytoma, ganglioglioma, oligodendroglioma, pilocytic astrocytoma. But in this patient, it's a ganglioglioma. The typical appearance is a cyst with an enhancing nodule. They most often occur in the temporal lobe, but they can occur anywhere. Calcifications are very frequent. They typically have a history of chronic epilepsy. The tumors are composed of mature ganglion cells, and they're WHO grade 1. A special variety of ganglioglioma, desmoplastic infantile astrocytoma and ganglioglioma, also called DIG. Solid nodule in the cortex with a large cyst that's deep to the solid tumor, and these are seen only in infants. They're also WHO grade 1. This is a T2 weighted image, funny looking lesion in the cerebellum. Stripes of alternating high and low intensity, little or no enhancement. This is Lermite Duclos. This is what it looks like on pathology. The other term for this is dysplastic cerebellar gangliocytoma, and has a very characteristic appearance of stripes of alternating high and low intensity on T2 weighted images, little or no enhancement, usually third and fourth decades. These are felt to be non-neoplastic lesions composed of hypertrophic neurons expanding the cerebellar folia. This is associated with Cowden syndrome, and it's a WHO grade 1. Flare T2 post-contrast T1. Lesion is centered in the cortex, has cyst-like areas. If I had diffusion-weighted images, it would show markedly increased diffusion, little or no enhancement. This is a dysembryoplastic neuroepithelial tumor, also called DNET. This is a cyst-like mass centered in the cortex, little or no enhancement. Young patients typically present with long-standing epilepsy. This one here, you can see it has remodeled the bone adjacent to it, and these are WHO grade 1. T2 and post-contrast T1 weighted images. We see a mass in the ventricle. It's attached to the septum pellucidum. Lots of enhancement. Our differential here would be meningioma, ependymoma, and central neurocytoma. This is a central neurocytoma. Just one thing here, this would be not a very good location for meningioma because meningiomas do not typically occur in the frontal horns. So central neurocytoma, interventricular mass attached to the septum pellucidum, strong enhancement. This is a WHO grade 2 lesion. and the differential is typically meningioma, ependymoma, or subependymoma. Subependymoma does not enhance with contrast. That's how we differentiate it from a central neurocytoma. Embryonal tumors, medulloblastoma, atypical teratoid rhabdoid tumor, and embryonal tumor not otherwise specified, also referred to as peanut. These are all WHO grade 4. Here we have T1 and post-contrast T1 showing this cerebellar fourth ventricular lesion. T2, ADC map, and perfusion images. So it's a heterogeneously enhancing mass, arises from the cerebellar vermis, elevated blood volume, reduced diffusion, medulloblastoma. You can see on the gross section, the lesion here arising from the roof of the fourth ventricle, in this case the inframedullary velum. So these tumors grow into the fourth ventricle. Rises from the roof of the fourth ventricle. They grow into the fourth ventricle and usually present with hydrocephalus. They have restricted diffusion, heterogeneous enhancement. Leptomeningeal metastases is very common, and these are WHO grade 4. Other embryonal tumors, the atypical teratoid rhabdoid tumor, and the supratentorial embryonal tumor, also referred to as peanut or primitive neuroectodermal tumor. So these are all embryonal tumors. Here we have T2, post-contrast T1, and diffusion weighted images. So we have a periventricular lesion, homogeneous enhancement, reduced diffusion. Typical appearance for lymphoma. Lymphoma is usually periventricular, has restricted diffusion. In immune-competent patients, the enhancement is very solid. In HIV patients, the tumors usually have rim enhancement. T2, post-contrast T1, gradient echo. It's a cerebellar enhancing mass. There are some dilated blood vessels that you can see next to it here. Blood products on the gradient echo images. Hemangioblastoma. These also occur in the spinal cord, in this case with a small enhancing tumor nodule and a big cyst next to it. Hemangioblastoma is the most common primary posterior fossa intraaxial tumor in adults. Remember, the vast majority of posterior fossa tumors in adults are metastases, but this is the most common primary posterior fossa tumor. When they're solitary, about a third of the time they're associated with the von Hippel-Lindau. The other 2/3 are sporadic. It's a hypervascular enhancing mass. The classic appearance, about 60% are a cyst with an enhancing nodule. The other 40%, like this case, are just a solid enhancing nodule, and these are WHO grade 1. Thanks for your attention.